Hi class, so we are going to be getting started on our spinal cord. So remember, the spinal cord is part of the CNS. The two components of the CNS are the brain and the spinal cord. So this is your CNS in a jar right here. Some FYIs for your information. The spinal cord in an adult is about 18 inches long. The diameter is about 3/4 of an inch. You all know it runs through the vertebral canal. And just to be sure you understand that the spinal cord is a continuation of the brain stem. The brain stem is part of the brain. The spinal cord starts right at the foramen magnum. So here's actually a better view. So here is the posterior part of the brain. Here's the skull. Here you can see the foramen magnum. Here's the foramen magnum here. Here's the space. Here's the skull on this side, and then that big hole, the foramen magnum. So here's the cerebellum of the brain. The brain stem is here. Now, once it passes through that foramen magnum, this is the spinal cord. So here is the spinal cord right here. So the spinal cord starts at the foramen magnum of the skull, and it continues down the vertebral column until about level L1, L2. That is lumbar vertebrae 1 to 2. Now, the functions of the spinal cord, we've already talked about spinal nerves a little bit. So remember, spinal nerves are in the PNS. Spinal nerves are connecting to the spinal cord, and it is through those spinal nerves that they are sending information into the spinal cord. The spinal cord is then sending that information up to the brain to be processed, and then once the brain figures out an action plan, it will send its commands back down through the spinal cord, and it will leave the spinal cord to where it needs to go through a spinal nerve. There are some spinal cord reflexes that we will talk about later, and basically a spinal cord reflex just means sensory comes in, it doesn't send the information up to the brain, and it just sends out a command straight away, straight from the spinal cord. The brain has nothing to do with it. So before I show you some more parts of the spinal cord, I just want to emphasize that the brain and spinal cord, the consistency of this nervous tissue is like soft tofu, maybe even a little bit softer than tofu, like gelatin. If you've ever had Jell-O, kind of like that. It is very, very soft, easy to damage this tissue. So we need to protect it. So the protection of the spinal cord, we're going to start with bone. It's a hard protection. We've already talked about the vertebral column. Remember the vertebral foramen here. So the spinal cord was going through these little foramen. So that's our first protection, is we have the bony protection of the vertebral column. Number 2 are meninges. Now these meninges are aka membranes. They are connective tissue membranes that are covering both the brain and continuing down and covering the spinal cord. And we'll talk about that very shortly. And cerebral spinal fluid, CSF. The spinal cord and the brain are suspended in a fluid-filled compartment. They are suspended in CSF. That is going to help protect the brain and the the spinal cord also. You need to know this. If you need to write it down on a card somewhere, write it down. Where does the spinal cord end? It ends at the level L1, L2. You need to know that. That's where the spinal cord ends. Now let's look at the spinal meninges. We said there were 3 connective tissue layers in our spinal meninges. And from the most superficial to deep, the most superficial is going to be the dura mater. Just deep to the dura is the arachnoid. And then the last one is the pia mater. Now, the most superficial, the dura mater, mater means mother, I think that is in German. And dura is hard, like it's durable, it's hard. This is a dense, irregular connective tissue, so it is strong, it is tough. And between the dura and the wall of the vertebral column is a space called the epidural space. Epidural. Epi means on top of. So it's going to be on top of the dura. And that epidural space is filled with adipose and blood vessels. So if you've ever had an epidural, that is where they were putting the numbing medicine, in this epidural space. And then what would happen is the numbing medicine would diffuse into the dura. And here's the dura right here. And that medicine, anesthetic, that numbing medicine would then numb the spinal nerves that are deep to the dura. But here is our epidural space. This is a spinal cord that's been dissected. They removed all the vertebral column, so just what's left, this is the spinal cord. Here is the fat in the epidural space. Fat is helping protect the spinal cord too. If you surround this with fat, it's adding another layer of protection. So fat is protecting it too. Here is the dura. Once we remove that epidural fat, this is what the dura is going to look like. Deep to this is going to be the spinal cord. You just cannot see it yet. So we said the dura mater. Now let's go on to the arachnoid. Now the arachnoid is just deep to the dura. It is a delicate connective tissue membrane that consists of spiderweb-like appearance of collagen and elastic fibers. Spiderweb appearance because arachnoid means spider. So here they have cut the dura. They have cut through the dura. They're pulling the dura over in this direction. They're holding the dura here. Here is the dura. Adhered to the dura right here, this shiny part right here, this is the arachnoid. Now they're pulling it, and you can see these spider webby looking strings down here. This is the subarachnoid space. Subarachnoid, it means deep to the arachnoid layer. This subarachnoid space is real important because this is where CSF is going to be flowing around the spinal cord and the brain. So subarachnoid space where CSF is flowing. Now the last meninges is the pia. The pia mater is a transparent, thin membrane, and it's attached to the surface of the spinal cord. So it's attached to this spinal cord. Now, we said the spinal cord ends at L1 and L2. I don't know if you can appreciate that this is actually spinal cord. This is spinal cord. You can see it over on this side too. This is spinal cord, and here it starts tapering. This tapering is called the conus medullaris. Conus medullaris. So if you need to write that on an index card, go ahead and do that because you will have to know what that is. And just inferior to this conus medullaris, there is going to be these structures. These are nerve roots. These nerve roots that are coming down at this distal end of the spinal cord and continue all the way down into the sacrum. This is called the cauda equina. Equina is something to do with a horse, like equine, it's a horse. So they call this the cauda equina because it looks like a horse's tail, and it does. So the pin is on the distal end of the spinal cord. This distal end of the spinal cord where it tapers is the conus medullaris. The probe right here is underneath the cauda equina. Here is the dura that has been pinned back. So you can see dura being pinned back. A little bit of subarachnoid right there. You can see the little spider webs down in there. Now, there's another structure you need to know. So this is the distal end of our spinal cord. And there is a structure called the filum terminale, the end filament. It is basically a strand of pia mater. Remember, pia mater is covering the spinal cord. And this filum terminale is going to be, it starts from the conus medullaris and it's going to go all the way down to the coccyx. Remember the coccyx, the tailbone? And that is going to help stabilize the spinal cord, because remember the spinal cord is floating in CSF and we don't want it moving, swaying back and forth. So this filum terminale is going to help tether it, to help pull it, I don't want to say pull it, hold it in place so it doesn't swing back and forth. And here is our cauda equina on either side here. Here is our dura that's been pinned back. So I'm going to just show you some other pictures of these meninges. Here is the dura up here that has not been cut. Here they have cut the dura and they've pulled it back. You can still see the arachnoid. The arachnoid did not come off on the dura here. The arachnoid is still right here. It is this thin membrane right here. And deep to that arachnoid would be the subarachnoid space where we would have our CSF. Can't really see you can kind of see the spinal cord here, but not real well because the arachnoid is still covering it. Here is another dissection. Here is the dura being pinned back right here. Here is the spinal cord. This is the conus medullaris, the tapering end of the spinal cord. Here is the filum terminale right there. That is so cool. Here is the cauda equina. Kind of looks like thin strands of noodles, doesn't it? I love this picture. When I saw this picture, I go, oh my God, this is so beautiful. You can really see the spinal cord right here. Here's the conus medullaris, beautiful. Here is the filum terminale. Here's the dura. The dura here. This is the dura in the back side. Remember, the dura is wrapping around this whole structure. This is beautiful. Now, this is just a picture. Once you've seen the real thing, pictures just are hard to look at. At least they're hard to look at for me. But this picture is showing you, this is what? This is the tapering end of the spinal cord. What is it called? The conus medullaris. Now, all this stuff is the cauda equina. These are the nerve roots, and they are going all the way down into the sacrum. Remember, you had those sacral foramen? That's where those nerve roots are going to actually exit through. So, kind of cool. This is showing you the dura. So, the CSF is going to be flowing all the way down to about this level here in the sacrum. What else do you need to know here? What level is this? Conus medullaris, what level is this? L1, L2. Here's the spinal cord model in the classroom. I'm just showing it because it's in our classroom. I'm not a great fan of it, though it's kind of good showing you what you need to know. Here you can kind of see this spinal cord here. This is showing you the brain, the spinal cord coming all the way down. But here is showing you a close-up of the distal end of the spinal cord. So what is this called? The distal end of the spinal cord is the conus medullaris. This structure that's coming off of the conus medullaris is what? That's going to be going down all the way to the coccyx. This is the filum terminale. And then they're showing you this is the cauda equina. So, why is it so important to know where the spinal cord ends? Well, especially when you're doing a lumbar puncture. So here is our vertebral column. Here's L1. L4 is about at the level of the iliac crest, and that's going to be real important when you're doing a lumbar puncture. That is your landmark. So your iliac crest is going to be your landmark for about L4. And you are going to be performing your spinal taps. You're going to be putting your needle in between lumbar level L3, L4. That's where you want to go. There's the X between L3, L4, or L4, L5. Those are the places you want to stick your needle. Why wouldn't you want to stick it up further, up higher? Because the spinal cord is ending around L1, L2. You don't want to accidentally stick a needle in the spinal cord. You can't do a lumbar puncture in the sacral region because this is solid bone back here. There is no space in between the vertebrae to get in. Here is showing you L1, L2. Here's the spinal cord is ending around that level. So what you need your patients to do is to flex the vertebral column. So when you flex that vertebral column, you are going to be opening up the spaces in between these spinous processes. Because it's hard to stick a needle in between the spinous processes when they're right like that. So you're going to have your patient flex the vertebral column, open this up. So this is showing you the needle going in here they're going actually in between L4 and L5, but normally it's done between either L3, L4, or L4, L5. You stick your needle in, you're going to go through the skin, the subcutaneous part of the skin. You're going to go through some ligaments, and then this purple structure is going to be the dura. You're going to pop through the dura, and you will feel that because it's such a stiff little membrane. You'll feel a pop, and then you're going to go into that subarachnoid space. And in this subarachnoid space is your CSF. This cauda equina, you're not going to harm them. They are floating in the CSF, and they will just move to the side when the needle comes in. So this is the best position to do a lumbar puncture or a spinal tap, having the patient lay in this position. And I am actually going to show you a little video that kind of goes through the anatomy, and they're going to show you how to do a lumbar puncture.
In adults, the spinal cord terminates at the level of the L1 vertebrae, and thus entry into the spinal canal must occur distal to this location. The fibers of the cauda equina extend distally from L1. However, they float freely in the CSF and are not likely to be injured by the advancing spinal needle. The L3-L4 or the L4-L5 interspace is the preferred location for lumbar puncture. Note that the L4 spinous process is at the level of the iliac crests, making these interspaces relatively easily identified. The spinous processes extend from the vertebral bodies in a caudal fashion. If the spinal needle is inserted perpendicular to the back, it will contact the superior surface of the spinous process below the selected interspace. Proper technique mandates that the needle be inserted in a cephalad direction, which will allow for entry into the spinal canal. During insertion, it is helpful to aim the needle toward the umbilicus or higher to facilitate proper needle trajectory. In the neutral anatomic position, the spinous processes are relatively close to each other, which may make lumbar puncture difficult. Instructing the patient to flex the back as much as possible will result in splaying of the spinous processes, which will facilitate entry into the spinal canal. Position the patient lying on her side in the fetal position, with the back flexed and at the edge of the bed. The spine should be parallel to the floor, and the plane of the back should be perpendicular to the bed. Careful attention to meticulous body positioning is essential in lumbar puncture. Incorrect positioning may cause the needle to contact the spinous processes or travel out of the anatomic midline, leading to failed dural puncture. Palpate the iliac crest, which is at the level of the L4 spinous process. Next, identify this spinous process as well as the interspaces directly above and below. Either the L3-L4 or the L4-L5 interspace may be chosen. Mark the entry site with a skin marking pen. Switch to sterile gloves and begin to prepare the area with chlorhexidine or povidone iodine. Use gradually increasing concentric circles to apply the antiseptic. Next, apply a sterile fenestrated drape over the region. Position the top of the drape over the patient's hip so that the iliac crest may be repalpated during the procedure if necessary. Place an additional sterile drape on the bed that can be used to hold equipment. Using a 25-gauge needle, place a wheel of local anesthetic in the epidermis overlying the selected interspace. It may be beneficial to palpate the spinous process during this step, but great caution must be exercised to avoid injuring yourself with the needle. Next, direct the 25-gauge needle through the wheel and inject an additional 1 to 2 milliliters of anesthetic. During anesthetic administration, direct the needle in a cephalad direction to facilitate proper passage through the spinous processes. Switch to a longer 22 or 25-gauge needle and begin to anesthetize the deeper tissues. Intermittently, pull back on the plunger during injection to exclude inadvertent vascular placement. Again, be sure to direct the needle in a cephalad direction. In general, between 3 and 5 milliliters of anesthetic are used. If you are using an atraumatic spinal needle, first pierce the skin with an 18 to 20 gauge beveled needle. This step facilitates entry of the relatively blunt-tipped needle through the epidermis. When inserting and advancing the spinal needle, rest your non-dominant hand against the patient's back and steady the needle with the thumb and index finger of this hand. This technique prevents inadvertent, uncontrolled displacement of the needle should the patient suddenly move. Begin to advance the needle toward the spinal canal in the anatomic midline, directed in a cephalad fashion aimed at the umbilicus. As you advance through the tissues, stop every 5 or 10 millimeters and withdraw the stylet to check for fluid return. If you meet bony resistance during advancement, the needle is likely contacting the spinous process inferior to the interspace and will need to be repositioned. First, withdraw the needle so that only the tip remains under the epidermis, and then redirect it in a more cephalad direction, aimed toward the umbilicus. You may feel a slight yet distinct popping sensation when the needle pierces the dura. Remove the stylet to check for fluid return. CSF will flow from the needle hub once the subarachnoid space has been entered. Next, attach the manometer to the hub and measure the opening pressure. Allow the glass column to fill and obtain the final reading. Normal pressures are less than 20 centimeters of water. Remove the manometer and begin to fill the specimen tubes. Recall that the tubes are numbered and must be filled sequentially for proper data analysis. A total of 4 tubes are filled, each with approximately 1 milliliter of spinal fluid. Additional fluid may be obtained if special studies, such as extended microbiological cultures and stains, are clinically indicated. Once the last tube has filled, reinsert the stylet and remove the needle. Finally, remove the drape, wash the back to remove the residual skin cleansing agent, and place a bandage over the puncture site.
Well, that's going to be it for this video on the spinal cord. So hopefully you have an appreciation for the gross anatomy of the spinal cord. In our next video, we'll go more into detail of the deeper structures.